everyone. In this episode, I interview Mr. Lester Barr, consultant breast surgeon. We discuss breast cancer. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for listening to my podcast. In this episode, I'm going to interview Mr. Lester Barr about breast cancer. Lester is a surgeon specializing in breast disease. He's the founder and chair of Prevent Breast Cancer, a charity aimed at funding research into the prevention of breast cancer in future generations. I feel privileged to have the opportunity to interview him on my podcast today. Lester, welcome. Thank you so much for agreeing to be interviewed on my podcast.
It's a great pleasure to be here. Thanks, Gail.
Lester, I always find it really interesting to learn why distinguished colleagues such as yourself choose their particular area of medicine. How did you end up caring for patients with breast cancer? And in particular, what made you interested in the prevention side of things?
Well, I did all of my surgical training in London, and I was lucky enough to work for a professor who was at the forefront of the move away from mastectomy surgery for everybody to trying to save the breast whenever possible. I then worked for another professor who was at the top of the field of bringing tamoxifen into clinical use. And then I spent 3 years working at the Royal Marsden Hospital in London, which many of your viewers will know as the cancer centre in London. And so when I moved up to Manchester, I moved up to a job that was cancer focused and specifically breast cancer focused.
Okay.
The prevention story is springs off from that because, again, many of your viewers may have been to a breast clinic and will know roughly how it works. So at the beginning of the morning, you may have 20 women coming with a breast lump or other symptom, and they go through the various tests. And thankfully, most of them will not have breast cancer because most breast lumps, breast symptoms are benign. But at the end of the morning, there's always one or two that have breast cancer. And so my job as the consultant was to sit down with them and say, look, I'm sorry, the tests show you've got breast cancer. Let's book you in for surgery in the diary. Following that, you're going to need radiotherapy. I think you might need chemotherapy. And so they start on that journey of treatment. And then the next day, it would be the same again. Another 20 women, another one or two. And then the next day, the same again. And so for me, it felt like I was a worker on a production line. And I was sending the patients off on their journey for surgery, chemo, etc. But the production line never stopped. Christmas, New Year, it just kept on running. And so it occurred to me, oh, hang on, why don't we do something to try and stop the conveyor belt running at all? Why don't we stop people coming onto the conveyor belt at the beginning and really focus on prevention? And at that time, 25 years ago, really nobody was talking about prevention. It was all about drug development, new treatments, and no emphasis at all on trying to prevent that conveyor belt of women going on that treatment journey. And that's where Prevent Breast Cancer was born.
Wow, gosh. And I think therein lies brilliance, where you're put in a situation that many others have been in before, but you can see something different and you can see a different opportunity. That was really fascinating. Thank you for sharing that with us. So Lester, as you know, this podcast is aimed at educating patients. Yeah. As a result, we do try to avoid medical terms so that it remains as accessible as possible to everyone. Yeah. So let's start with the very basics. What are the symptoms of breast cancer?
Well, of course, the most common is finding a lump. And that lump may be found by you or by your partner or on a routine mammogram. There are some others as well. So nipple inversion out of the blue, nipple bleeding, nipple skin change, indentation of the skin of the breast, a patch of inflammation for no good reason. Sometimes it's a lump under your arm that you feel. So this is October 2022. This is Breast Cancer Awareness Month. There's loads of resources out there which list all these things. Many women are very familiar with them. But the point is, if you have a new breast symptom, you go to your GP and they will then send you in to your nearest breast clinic.
Okay, thank you. So that's really interesting, because I think the average person, if you just asked what are the symptoms of breast cancer that you worry about, that you look for, I think 99% would probably say a breast lump. And if pushed further, I don't know how many people would say, well, your nipple, a new finding of your nipple, it looks different, the skin looks different on your breast. So that's really, really valuable for women to know what they should look out for, apart from just having a feel of your breasts regularly, as is advised. So are there any risk factors for breast cancer? So I always ask about risk factors because some risk factors for certain conditions you cannot change, like you cannot change, I guess, your genetic makeup, you can't change that. But there are certain risk factors that can be changed. For example, lifestyle changes can decrease the risk of getting many various conditions in different ways. So are there any risk factors that you could care to mention to talk a little bit about? And can it be prevented? And I guess that is, I'm asking the right man, if it can be prevented, and how so?
Okay, so there is no one thing that causes breast cancer. It's a combination of the genes you're born with, plus the environment in which you grow up, the country where you grew up, and some lifestyle factors. So in trying to think about how do you prevent breast cancer, you have to think about all of those different things. So if we think first of all about the genetics of breast cancer, then the situation has really dramatically changed over the last 20 years. The familial breast cancer cases were a worry 20, 25 years ago, because there were families where almost half of the women in that family were getting breast cancer, and many of them dying of it quite young. And then a gene called BRCA1 was found, and then a second breast cancer gene, BRCA2. And then over the last 20 years, we think most of the high-risk genes for breast cancer. So whereas 20 years ago, this was a very scary place to be in one of those families. My mother's had it, my aunties had it, my sister's just had it. Is it me going to be next? Well, over the last 20 years, the situation's utterly transformed, because we can now test for these genes and we can do things to help those families. I think most people know about preventative surgery, but that's not for everyone. We do have the option of regular testing, MR scanning. We have some preventative tablets that you can take to lower your risk. And so for women nowadays who come from one of these families where breast cancer has devastated generations of women, the outlook now is excellent, and your life expectancy appears to be the same as if you didn't carry a gene at all. So it really has transformed.
Wow, that's amazing.
Having worked out the prediction techniques, which is a combination of looking at your genetics, things called SNPs, which are little gene fragments, plus your breast density, which some of your viewers may have heard of as a risk factor, plus also your lifestyle. Having done that, what do we do to prevent breast cancer? Well, increase screening for those who are at higher risk, because that way we can sometimes pick up breast cancer before it's really got going, maybe as a pre-cancer or as a tiny little thing. And if you nip it out quickly, then you don't need chemotherapy, and it's a much easier journey. And for those who want to alter their lifestyle, yes, there are some things that we can do. And it will be no surprise that it seems that healthy diet, Mediterranean style, whole foods, avoiding processed food, plus regular exercise, those are high on the list. And then minimising the amount of artificial chemicals that you take in, particularly things like contraceptive pill, HRT, those sort of things. For some women, those can be a risk factor, and so we might advise reducing those. So I think we're on the threshold of being able to put into place some improvements to the breast screening program to tailor it to an individual person and their individual risk, and then put into place some preventative strategies. We're also working on preventative drugs. We have actually got 3 drugs at the moment that are approved by the NHS for breast cancer prevention. They come with side effects, of course, and so we're now trying to develop newer drugs that would prevent breast cancer without as many side effects. So that's also quite an exciting area of development, which I think will bear fruit in the years to come.
Wow, that's an amazingly comprehensive answer. So women who do have a family history of breast cancer, what would you recommend that they do if they know about it? Maybe they've not faced it, or maybe they've not got any advice about it. Would you recommend them to go along, and would they be eligible for these, or are these just models that you are working on, or are they actually available in the NHS or anywhere in the UK?
Yes, up and down the country, the NHS provides clinics known as family history clinics to which your GP can refer you. It needs to be a first degree relative. It needs to be your sister or your mum.
Okay.
And particularly if they've had breast cancer at an early age, you can be sent to a family history clinic who will assess your risk. They may offer you a genetic test, and then they will give you a plan, a program for you. For those at the very high end, it will be a checkup every 6 months, alternating a mammogram and an MR scan. For those in the middle, it may be, instead of having a mammogram every 3 years, starting at 50, you'll have a mammogram every 1 year, starting at 35. So yes, there are things that are available on the NHS. Interestingly, gene testing is commercially available as well. So if you don't meet the NHS criteria, you can actually buy a gene test these days. And many women do that because even if the chance of the gene being present is quite small, people like to know.
Yes.
So you can buy a gene test for a few £100, but thankfully the NHS will provide that service through the Family History Clinic network up and down the country.
Okay, brilliant. So you've answered my next question before I've asked it, which is, so if you didn't have a family history, but you were worried because it seems really common, breast cancer, there is a way that you can get more information for yourself. Great, thank you. So in terms of women who do have, or if you say you feel a lump or you've got a nipple change and you worry about it and you go along to your GP, how is it diagnosed? So what can a patient expect to be their journey? So you mentioned a little bit about when you were in the clinics and, they had this, that, another test. Can you just kind of tease it out in a bit more detail as to, you've got a breast lump, you should go to your GP. What can you expect to happen next? You're
going to arrive at the breast clinic and they will send you for probably 2 tests, maybe even 3. If you're under 40, you'll have an ultrasound scan. If you're over 40, it will probably be a mammogram, sometimes both. And if a lump is present, then you will undoubtedly have a needle test, which isn't as bad as it sounds. A little bit of anaesthetic is used. And it's like having a blood test, I guess. Nobody enjoys it, but it's just a pinprick. And instead of taking a sample of blood, you take a sample of the lump, and that gets sent off for analysis. And sometimes they can tell you within a day, what the lump is. Sometimes they will have to bring you back the following week when the biopsy results are available. But that's generally how a breast clinic works. And just to repeat again, for every 20 women who come to a breast clinic, probably only 1 or maybe 2 will have breast cancer, and the others will not.
Okay. And what about time scale? So is the time frame, I guess the answer to the question is yes, but is the time frame between symptoms? So maybe I'm having a shower this morning and I feel a lump in my breast that I've not felt before. How important is the time frame between feeling that lump in the first place and going for medical attention and to be investigated in order to be diagnosed? How important is that? Should I just wait and see if the lump goes away? Should I do it as a matter of urgency? Maybe, I guess it depends on the symptoms, but if there is any change in your breast that you think, oh, that was not there, for the 45 years or whatever that I've been alive, it's a new finding. How important is it to go along quickly?
Well, the NHS has a thing called the 2-week rule. So when you make contact with your GP, they can refer you to a breast clinic, and the rule is that you're meant to have an appointment within 2 weeks. So yes, getting through the system quickly is important. There are some women, however, who get hormonal breast lumps, and particularly if you're prone to getting several lumps over a period of time, it's quite safe to leave going to the doctor until your next monthly cycle, because a lot of hormonal lumps will flare up and then settle down after your period, and that's very reassuring. So I think if somebody thinks, I'm not sure what that is, leaving it for your next monthly cycle, has it gone? Yes, it has, then you can relax. But if it's still there, then you should contact your GP, and then hopefully the 2-week rule will kick in. You'll have an assessment, and hopefully you'll be one of the many who go home with good news. Okay, perfect. So thank you for that. It's really, really, really valuable, because what we don't want to do is alarm women unnecessarily and, have loads of women go in for a temporary finding that's just hormonal and cyclical, perhaps. But then we don't want women to wait too long, be sure to reassess things so that they do get their diagnosis in good time. But that's really, really valuable piece of information. Okay. So for argument's sake, you go to the clinic, you feel a breast lump, it's there after a cycle, you go along to the clinic, you have the investigations, and you are diagnosed as having breast cancer. Can you talk us through what treatment options are likely to be discussed with you? And I'm sure this varies depending on extent, size, etc. But, that's for you to tell us. I'm kind of guessing. What treatment options are available and how effective are they? Can you speak a little bit about that for us, please? Yes, well, there are 3 categories of treatment. So for most women, the first category to think about is surgery. And if it's a small lump, it'll be a small operation. If it's a big lump, it'll be a bigger operation. So surgery is often a key part of the breast cancer treatment. And for many women, surgery is curative. The second treatment that we have is called radiotherapy or radiation. And we use that particularly for women who don't need a mastectomy, because the combination of a small operation, lumpectomy operation, combined with radiotherapy gives exactly the same cure rate as having a full mastectomy operation. And so radiotherapy is commonly used. It's pain-free and very straightforward. You just sit in front of a machine and it does the treatment for you. For many women, that will be a standard recommendation to minimize the chance of any recurrence. And then the third category we have is drug treatment. Some of those drugs are just tablets. I mentioned earlier a drug called tamoxifen, which many women have heard of, which has really transformed the cure rates for breast cancer right across the world. It's been a fantastic drug in terms of its ability to improve cures. But we have other tablet drugs as well, which may or may not be suitable for an individual person, and so you'll have a discussion about those drugs. There's then the chemotherapy drugs, and if you again have a particular type of breast cancer, maybe one that's a bit more aggressive, or maybe it's spread a bit further, then it's likely we'll give you chemotherapy. And chemotherapy again has just transformed the survival chances. It really works. Of course it comes with side effects, it's not fun, but for many women it really does save lives. And then another category of drugs we have, there are sort of designer drugs. So with these newer drugs, we can target particular types of breast cancer. Some of them block particular pathways that cancer cells use. Some of them use the immune system. That's known as immunotherapy. And one of the jobs of the specialist is to choose the very best drug for your type of breast cancer, because there are loads of different types of breast cancer. They're not all the same. And so on the shelf, as it were, we have a whole load of different options of drugs that we can give you to improve your chances. And I guess the key thing is to ask your specialist what drugs will work for me, and what kind of balance is there between improving my cure chances and the side effects that I have to put up with. And they'll have a very frank discussion with you. And if they really think you should have a particular drug, they'll say, look, I really recommend this because this can really improve your chances of cure.
Okay, thank you for that. So it's interesting because I don't think the average person realizes how much therapy can be tailored to the individual, depending on the individual themselves, side effects, the type of cancer, the stage, I guess. I think many women think that breast cancer means I'm going to lose my breast, which you said is not necessarily the case, and it's much less frequent that way now than it used to be, and that the treatment options for breast cancer, as well as for prevention, have moved on amazingly over the past few years. So thank you for those brilliant and clear answers to my questions. As you know, I asked listeners beforehand if there's anything that they'd like me to ask on their behalf. And some questions have been submitted. Is it okay if I ask the questions that listeners have sent in?
Listeners' questions, yeah, love them.
Perfect. That's what I think too. So I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, etc. Also, due to time constraints, I have summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. Okay, so the first question is, do you think the frequency of breast cancer is on the increase? This listener says, I know so many people who've had breast cancer that it seems to be more frequent than it used to be.
Yes, it is. It's gradually rising. It has been in Western countries for the last 3 or 4 decades, but continuing to rise. And it's rising across all age groups. So if you look at women in their 20s and 30s, it's going up. Women in the 40s, it's going up. Women in the 50s, it's going up. And this is almost certainly because of lifestyle choices and changes. Some of them are things that you can't really do much about, I guess. So the age at which you have your first child, that's a risk factor, and it just so happens that our society, we're having our children later.
Yeah.
Breastfeeding is protective, but more women don't breastfeed, and so that's a risk factor. Unhealthy diet and alcohol consumption. So again, that's a societal change that we've seen that is pushing breast cancer rates up. So yes, it is becoming more common, and again, that's one of the motivations why I really do feel that the strategy that Prevent Breast Cancer is following to try and stop it at the beginning is so important, because if we can turn around some of those risk factors, improve the screening of breast lumps and breast cancer by, instead of starting at 50, we really should be starting at a much younger age. And putting much more emphasis on cancer prevention. I really think that's what we need in order to stop this gradual rise, continuing rise. And the other really interesting thing is that the biggest rises in breast cancer are occurring in what's sometimes called third world countries. So in Central America, Africa, Asia. As countries become more westernized, their breast cancer rates are rising. So it's not just an issue for the UK, but it's a worldwide issue, and it's so important that we can work out these factors that are driving it up so that we can then begin to drive it down.
Okay, brilliant. Okay, so our second question is from a concerned partner who says, my girlfriend tends to have this constant pain in one of her breasts, the left one, when touched. And secondly, the same breast is slightly larger than the right one. What's the cause of it being asymmetrical? And I guess the unasked question is this an abnormality that she needs checking out?
Well, it sounds as if there are two separate issues here. One is the breast pain, and the other is the asymmetry. So I'll deal with them separately. Now, breast pain is, for the vast majority of people, completely harmless. And it's most unusual for a breast cancer to present with pain. The majority of them are painless. Now, you'd have thought that if you had breast pain, it would affect both of them the same. Now, for premenstrual breast tenderness, that's often the case. But sometimes one breast can misbehave. It's often just one corner of one breast, for some odd reason, misbehaves. And the way it's been explained to me, which I think is quite helpful, is that your breasts are not twins, they're sisters. And sometimes they behave quite differently. And so when somebody comes to clinic with breast pain, one part of one breast, usually the tests are negative, and it just needs a bit of reassurance. The asymmetry issue, some girls are, as they develop, have really quite different size and shape of breast. For others, and in fact, some would say really pretty well for everybody, your breasts are never identical. And there's often a difference in the size of your two breasts. But if that difference becomes more than 1 cup size, maybe it's 2 cup sizes different, that goes by the medical name of breast asymmetry. And most breast surgeons would be happy to fix that on the NHS. It might mean reducing one to match the other. It might mean augmenting one to match the other, or sometimes it's a combination of the two. So if it's really marked asymmetry, then yes, please get your doctor to refer you to a breast surgeon to have a look at it. On the other hand, if it's less, let's say it's less than a cup size different, then my message would be that's normal, and embrace it and don't worry. That is just a normal thing that many women have.
Yeah. Okay, brilliant. Wow, brilliant answer. Okay, so the third question is, could you please discuss the best practice for psychological support following surgical interventions for breast cancer?
Okay, so
best practice for psychological support.
the question is, what's the best practice? And I think the way I would answer that is that there isn't any one best practice, because people are so different. So, for example, support groups. Some women love them because they can build a community of others who've been through what they've been through and find that extremely helpful. Other women hate them and just don't want to be part of a support group at all. And it's not that one is right and the other is wrong. It is such an individual thing. Every woman with breast cancer should be allocated to a breast care nurse. And breast care nurses, as well as offering practical support and advice, also will offer some emotional support. And I would say that the best practice is indeed to link in with your breast care nurse. Most of them are very experienced and very good to get that sort of advice and support through the journey. Similarly, if you're having chemotherapy, you'll usually be allocated to a chemotherapy nurse. And again, they'll try to give you emotional support. If that doesn't work, then most cancer centres will have a psychological support team with a clinical psychologist. And you can just escalate it up to that next level. And if you're really, really struggling, then you can escalate it up to seeing a psychiatrist who will help you maybe with medication for a while. It's worth bearing in mind that a significant number of women going through breast cancer will become significantly depressed for a while. And it usually is a while, maybe 6 months or a year, where they have a real dip. And if that dip is a dark and horrible place, then I really would encourage you to go through that process of breast care nurse, psychological support, and maybe some psychiatric input, so that you're on maybe an antidepressant for 6 months. And then you'll come through the other side. That would be a typical journey. And then, of course, there's nothing more valuable than supportive friends and family. And again, people can be very different in the way they approach that. Some will be very open and tell everybody at the school gate, I've got breast cancer, and people will come around and hopefully support you. Others are much more private and really don't want anyone else to know, and so it's kept closed within the family. And again, it's not that one is better than the other. Both approaches are perfectly normal approaches. So do what you think is best for you, and if that is to share, then share, and if it is to just retain it within a very small group, then do that. But I would encourage you always to share it with at least one other person. Don't do this on your own. It's too difficult to do on your own. Trust somebody with that news and with that information to come alongside you as a bit of a supporter.
Yeah, great, good advice. So basically, again, tailored to your need. The support is there, but just feel free and have a really low threshold to reach out for it. Yeah. Okay. So moving on to a more technical question. This listener says, what I'd like to ask him is, can cutaneous or subcutaneous metastases be surgically removed? And if you'd just like to explain what metastases are. So she goes on to say, I can feel all mine on the abdominal wall and have 2 on my scalp, one of which is now weeping. My oncologist is not in favour of excision, but rather start paclitaxel and see how things go. I'm aware the treatment will have to stop for surgery.
Yeah, okay, so this is quite unusual, but if you've had breast cancer, yes, it can produce metastases, which the lay term would be secondaries. It spreads somewhere else and then makes a lump somewhere else. And in some unusual cases, that can be in the skin. It can present with a skin lump. They can be surgically removed if they're a nuisance, but many oncologists like to leave them in place. And the reason that they leave them in place is that they call them a marker. So you might start a new drug like paclitaxel. If the lump shrinks, that's a marker that the drug is working. If the drug doesn't make it shrink, then it's a mark that the drug's not working and maybe you should switch to something else. That's the sort of reasoning that an oncologist would have in deciding what's the best management of a metastasis that is surgically removable. The other point to make is that it doesn't improve your long-term cure. Whether or not you're cured long-term depends on how effective the treatments are, how your body reacts to it, and simply removing 1 or 2 or 3 won't affect the outcome. And that's why oncologists like sometimes to leave them as a marker, because the real priority is to give you the very best drug that he's got up his sleeve.
So just off the top of my head, so in view of what you said, if they are particularly bothersome, or maybe some are particularly bothersome, would it be reasonable to maybe remove the ones that are bothering you if you still have the marker? Or is it valuable to see the distribution and the progression of all of them?
Yes,
Does that make sense? You know, like this viewer says, the one on the head that's weeping on the scalp, you know,
possibly.
Maybe that one could come out.
And that would be a discussion that you would have with your oncologist and your surgeon. But yeah, that would be a possibility.
Okay, that's an amazing point, though. Really good point. Okay, so the next question is: my doctor said that he will test my lymph nodes with a test called Sentinel lymph node biopsy, and that we will stop there, even if it comes back as positive. So even if this lymph node is positive, no more treatment. When I came home, I spoke to some of my friends and some in the same situation. So maybe this person's in one of those support groups, who went on to have more lymph node surgery. As a patient, I find this very confusing. Can you clarify at all why one woman may have one treatment plan depending on a positive lymph node biopsy, whereas the other is offered surgery?
Yes, so let's just take it back a stage. Breast cancer can spread into the lymph nodes under your arm, and as well as biopsying the lump in the breast, we like to take a biopsy of the lymph nodes under your arm. That biopsy might be taken in the clinic. If the scan shows, that's an abnormal lymph gland, then in clinic they'll take a needle biopsy from it. But if it looks okay on the scan, you'll still have a biopsy done of that lymph node under anaesthetic in theatre when you're having your breast surgery. And then when you come back for your results, they will say your lymph node biopsy, the technical term is sentinel node biopsy. The word sentinel means standing guard. So they biopsy the lymph gland under your arm that's standing guard over the breast. That would be the very first one to pick up some cancer cells. And if there's cancer cells in that lymph gland, then another decision needs to be made, which is what additional treatment should we do in the light of this positive lymph gland? For some women, that will be additional surgery, removing the remainder of the lymph glands. For some, it will be additional radiotherapy. You can have radiotherapy going up into the axilla to supplement the radiotherapy to the breast. And for others, it may just be a wait and watch approach. Particularly women having chemotherapy, it may be that the priority is let's just get on with your chemo, and then hopefully that will deal with any little cells that are left behind in the axilla. So it's an individualized decision-making process, which depends on your particular type of breast cancer and how badly the lymph node is affected. And also, it does depend a little bit from one hospital to another, because we're going through a time of transition where we're trying not to do as much lymph node surgery as in the past. So some units are much more keen on a wait and watch policy, and others are more keen on let's go back in and do a second operation. So there are clinical trials currently underway. The ones that have been completed so far seem to indicate that both policies have an equivalent outcome, whether it's wait and watch or cancer surgery. So I don't think you're coming to any harm by not having the additional surgery, but that's the sort of reason why there's a difference of approach between different people. It may depend on your type of breast cancer, how badly this is affected, what additional treatments are available, and I think you just have to put yourself in the hands of a unit that you trust, of an oncology team that are going to advise you as to what's best for you.
Yeah, and I guess that the types of breast cancer are, like you said, repeatedly different, so you can't really compare with your friend necessarily, expect to have exactly the same treatment, the treatment offered, because the care is so individualized that the treatment appropriate treatment may be different for two women who, to them seem to have the same issue, but they don't really when you look into in detail.
Yeah.
Does that make sense?
Right, yeah.
Is that right?
Yeah.
Yeah. Okay. So our last, I believe, question from our listeners is that I've been reading up on my hormonal tablets, and she's not specified which tablet. You said before that there were several, which have been prescribed after my surgery and radiotherapy. I've been looking online, and some people get it for 5 or 7 years and some longer. How do I know which is right for me? And is it safe to take it for so long?
Okay, so the standard recommendation used to be 5 years of treatment. Then the standard used to be 7 years of treatment with a switch from one drug to another in the middle. And then there are some studies that say, well, actually 10 years is pretty good. 10 years may be better than 5. And some women even go on beyond 10 years. And when you get to the longer time frame, like the 7-year point and the 10-year point, the decision often is a balance between effectiveness and side effects. So if you reach let's say you reach the 5-year point, but you're struggling with side effects, then it's perfectly reasonable to say, do you know what, you've had 5 years, and that's going to give you that's going to give you a real big chunk of extra benefit. However, if you're not too bothered by the side effects, then carry on for 7. And again, have the same discussion. What are your side effects like? And if it's not too bad, you can carry on for 10. In terms of the risks, there's the drug that we've mentioned already called tamoxifen, has 2 risks that you need to be aware of. One is deep vein thrombosis, sometimes called economy class syndrome. So if you're going on a long haul flight, you should definitely wear flight socks, avoid alcohol, and possibly even stop your tamoxifen for a few days while before you fly. The other side effect is called endometrial cancer of the womb. It just bobs up the risk of that a little bit. So tamoxifen is perfectly safe from that point of view if you've had a hysterectomy. But if you've not had a hysterectomy, then it becomes a little factor, and you might say, well, actually, maybe at 5 years we'll stop your tamoxifen. We could even switch you to something different. So those are the two things to be aware of. The other big class of drugs are technically known as aromatase inhibitors. There's a drug called anastrozole, another one called letrozole, which this particular questioner might be on. And its main long-term effect is thinning of the bone, or putting you at risk of osteoporosis. And that's relatively straightforward to compensate for by having regular bone density scans and taking some bone strengthening medication. Even some vitamin D and calcium can help. So I wouldn't have any hesitation in having somebody on one of these drugs for 7 years or 10 years. And the other factor is, what was your original breast cancer like? So if it's a little tiny thing, not spread, really excellent prognosis, 5 years might be the best for you to minimize the side effects. But if you've had a larger breast cancer, you've had chemo, and the type of breast cancer is potentially more likely to return, then 10 years might be a good thing to do. And I've certainly had many women who reach the 10-year point and say, do you know what, I'm having no side effects from this medication, I'm going to carry on as a preventative. And that's another interesting thing, which is that there are now many women who take these drugs, like tamoxifen, like anastrozole, like letrozole. They've never had breast cancer, but it's in the family. Maybe they have a gene, maybe they don't, but nevertheless, it's a strong family history. And so they take it as a preventative for typically for 5 years if it's just a preventative. So the rationale shifts from being a treatment to being a preventative. And so I'm certainly in favour of taking these drugs relatively long term because of that preventative effect.
Okay. And I can't resist at this point as a gynecologist to say, and if you have abnormal bleeding on the tamoxifen, please go see a gynecologist to be investigated, so that the endometrium or the lining of the womb can be investigated.
It's an extremely good
Sorry
point.
if I had to put that in. So, Lester, thank you for answering all the questions from listeners and so comprehensively. Thank you very much. And being so articulate and eloquent as well.
Okay.
I've got one closing question, and that's from myself. And that is that you have seen many, many, many patients with breast cancer in your career. Given the opportunity, is there anything that you'd like to say to patients who think that they may have breast cancer or have been diagnosed with breast cancer?
I guess there's a couple of broad things that are worth saying. The first is that the cure rates for breast cancer have dramatically improved as the years have gone by. And so please do engage with your medical team and your oncologist. The prospect of some of these drugs may sound scary and horrible, but they really, really do work, and we can massively improve your chances of cure if you go along that pathway. I guess the second thing I would say is that I think for the future, rather than developing more and more treatments and more drugs, there's a limit to what that can achieve. One vision of the future is that breast cancer becomes a little bit like diabetes. In other words, you live with it, but you're always on some kind of drug to keep it at bay. I don't think that's a good enough vision, as it were, for the future. I think a much better vision for the future is to really let's work on the prevention end of things. And that's going to take another decade or two, I think, to really crack. So the organisation that I head up, Prevent Breast Cancer, it's well worth having a look at our website, seeing the sort of things that we do, not just on the sort of fundraising side, but some information in there about the research that we fund. And so I think looking to the future, I think that research into prevention is at least as important as research into newer chemotherapy drugs. And that I think would be my final message.
Okay, so thanks for that. And I will put a link to the Prevent breast cancer website with the podcast for interested people. So in closing, Lester, I would like to thank you so much for coming onto my podcast and sharing your knowledge with us today. And most of all, for your hard work and years of dedication in the field of breast cancer, and in particular, your invaluable work on breast cancer prevention. It's really a bright light at the end of the tunnel of breast cancer for every woman, including myself. Thank you so much.
Bye-bye.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.